So you guys have kind of formed a team, and correct me if I'm wrong, and you come to the conclusion, or you believe that you might have discovered that there's an association between the androgen receptor and a risk of greater severity of the disease when it comes to COVID-19 infection. Maybe one of you guys can start explaining that to me.
Well, there's this protein called TMPRSS2, which is a protease. It's a protein that digests other proteins. And this protein, it's only produced by androgen hormones. So the person has to have a hormone to bind to a receptor, which is called the androgen receptor, so this protease can be produced by the body.
Okay.
Now, one thing that is very important for COVID-19 is that this protease, it works like a lubricant for the virus. So the virus can enter our cells only if it's primed by this protease. Otherwise, it won't match our cells. We cannot get inside our cells. So after priming, the virus can go to the receptor and get inside our cells. So it is actually the first step for the infection, this priming of the spikes of the virus.
Now, how did you guys, let me cut you off. How did you guys discover this?
So actually, it started with hair loss. So I've actually worked with, as I said, with Dr. Wambier, and in fact, I've known Dr. Washenik for probably a decade as well on hair loss. I was the first one who brought genetic testing, product called HairDX, and I think that was more than a decade ago, for hair loss. We discovered genetic variances that predispose, and that's actually how I know you also, Spencer, genetic variances that predispose men and later women to hair loss, androgenetic alopecia. So we kind of have a very maniacal focus of only looking at hair, and I just noticed that men and women have a big disparity. And then if you look at prepubescent children, same thing. There's a big disparity in mortality and disease severity rate between them. So we thought, hey, maybe there is, androgens are involved in a lot of things, but then, people say smoking can also cause this difference between men and women and a million other things. But androgen seems a reasonable thing to look at. So the theory sort of started with that, and Dr. Wambier and I started discussing that, and then the next thing that we find is that, oh, by the way, that protein he's mentioning, which is essential, and I guess it's necessary but not sufficient for the COVID-19 causing virus, SARS-CoV-2, to enter into the cell. Well, that appears to be dependent on androgen, solely on androgens in the human body, at least, as far as we know. And then there are actually two other proteins. One is called the ACE2. I'm sure you've heard a lot about it recently.
Sure.
Which actually requires the anchoring of the virus to the cell. So the virus to enter the cell, it needs to anchor to it and somehow has this spike that needs to enter the cell and open it up, and then it can reproduce itself. Well, both of these conditions require androgens to some effect. And then this is what I call the third leg of the stool, which is pulmonary secretions, which protect the lungs against pathogens in general, and those are inversely related to androgen levels. So the more androgens you produce, the more likely actually you can have an infection. So that explains some of the differential between men and women. So interesting, you have three pieces here that kind of line up together. And even more exciting to us was when Dr. Wambier and I made this prediction that we think that in African-American people, you might have a higher mortality rate. And taking all the issues of there might be inequality in the medical system, and we're aware of all that, so that's not to take away from the issue. But the fact is that if you look at the African-American population and males, they carry a genetic variant that predisposes them to higher rates of both prostate cancer and androgenetic alopecia. Well, those are related to more androgen sensitivity. And so we sort of predicted this could be an issue in the overall population. So there, all these pieces sort of fit into an androgen-mediated model for COVID-19 disease severity and mortality.
This may sound a little selfish, but are you guys implying that I may be kind of immune to this because I've been on ProScar for almost 25 years?
Oh, possibly. So, at least you.
So we have no data. Yeah, we don't have data on that, and I think that's important. Spencer.
Yes,
because
we don't have we don't have data on the population now regarding hair loss, but we surely have data that this protease is drastically reduced with finasteride, because this protease has been studied vastly on the prostate, because this protease, TMPRSS2, is the main protease that causes prostate cancer. So we know that the androgen that goes to this gene to produce this protease is intrinsically related to the size of the prostate. And we know that by using finasteride, we just knock down the expression of this protease. So yes, we have a lot of data from more than 10 years ago saying that we just stopped this protease. And this protease, remember what I said, it's the lubricant that the virus uses to actually match to our cells. And so, yes, we never tested this in the coronavirus to know if this hypothesis is true. But based on everything we know about coronavirus and also the statistics, that males are much more in danger than females, and they even die more. Men die more than women from coronavirus.
I think that Ken wanted to put a caveat out there, and I think maybe we should allow that to happen.
Yeah, I think it's important, Spencer, because what we have here are some interesting observations, some dots that are very provocative, that if connected, could yield a really unexpected lead at therapies that currently exist. And that would be that the possibility of blocking the androgen receptor to someone who has acute lung disease and COVID-19 infection could benefit them. Now, one of the co-authors on a couple of these manuscripts, Dr. Van Galvin, went through and did a very, very cursory observation of men hospitalized in a couple of the hospitals in Spain, and felt that, without doing strict statistics, that there was a higher incidence of people with more advanced hair loss in the male population than less advanced, that had a more severe case or more involved case of the COVID-19 pneumonia. So it's very provocative, but the data is not there. The next step that would be really important to do would be to go through, as Dr. Wambier just talked about. Carlos said the effects on the prostate of 5-alpha reductase inhibitors. But what we have to do is see, do those people who are in the hospital who have severe disease or advanced disease, are they already on therapy for prostates or for hair loss? Sure. In which case, it would indicate it was less likely to provide a therapeutic advantage. But if not, then yes, anti-androgens, and maybe even more so an acute anti-androgen like something like flutamide, enzalutamide, things that immediately block the androgen receptor could give acute relief. But that was the only point I was trying to make.
I was going to ask you that question, because I mean, finasteride takes 10, 14 days to get to the point where you're lowering your DHT to a significant degree past your baseline. So it couldn't be, I don't know, correct me if I'm wrong, but...
Well, it could be used as a prophylactic. So our idea was there are antagonists. So anti-androgen is a large category of drugs. So if this theory shows promise, in trials, I would imagine that for people who are hospitalized, you would need something that is a far stronger anti-androgen and faster acting, something like those flutamide, like glutamide, drugs that are actually antagonists, and they're used in prostate cancer. They do carry a much higher set of adverse events, even though they're probably not going to be used chronically. The alternative, what we're talking also is a possibility, and that's going back to your question about whether you're immune to it from finasteride. Well, I wouldn't use the immune, but if our theory shows that, some promise in that, there's a chance that people who are taking long-term finasteride might show less symptoms or less likely to contract the virus. But that's finasteride or dutasteride probably is a better one in this particular case, have longer time to act, but they could be used in both military personnel, healthcare workers, and in fact, that's what we're trying to study, is to see if healthcare workers who actually are disproportionately affected by COVID-19, whether prophylactic uses for, let's say, 90 days, is going to reduce the rate of infection. As far as the epidemiology to look at, it's interesting, but there's only so much you can conclude from epidemiological studies, especially when this is such a mass emergency on such a large scale. It's really hard to get patient records and what drugs have been taken and how they've been taken and combine it all with the outcomes that they're having. So that's the problem I've had dealing with I'm affiliated with several universities around the world. And it has been a problem to get an integrated record from the patient who's been hospitalized for COVID-19.
Yeah, but there's also a thought
there's
also a thought that perhaps the use of hydrochloroquine, even prophylactically, even though there's a lot of controversy right now, may benefit patients as well from a different mechanism. So, I mean, what do you guys think about that?
Actually, hydroxychloroquine, there is a study that shows that it is possibly also an anti-androgen. I can't comment, at least not from my side. Maybe Ken or Carlos can comment more about that, but I don't know more about those studies.
So there are a few things here, Spencer, that have, as Andy and Carlos have said, just been provocative. That you say, okay, we've got these isolated facts, and is there a unifying concept? And you take one. That's the hypothesis. That's the androgen receptor. We also know that that it's related to lung inflammation and the production of surfactants in the lung. I think Andy and Carlos both spoke to the fact that this type 2 pneumocyte, a certain kind of cell in the lung, expresses this angiotensin converting enzyme 2. It needs this serine 2 protease, also that's bound on the membrane, and so it exposes that particular cell type to the danger of the virus. Flip side of that is estrogen. So with age, as people get older, you see more people falling prey to advanced disease with COVID-19, and estrogen is somewhat protective. And as people, women become postmenopausal, their estrogen levels go down, and their androgen levels are less protected from, even though they have lower levels. So, another possible piece of evidence that says an endocrinologic link exists between the severity of lung damage and the androgen receptor.
But aren't older men dealing with higher levels of estrogen as well? And could that be protective in some way?
Yeah. Well, the androgen receptor, interestingly enough, even though there's a decline in androgens in men over time, it's a point that somebody asked me before. I found a paper that demonstrated over, obviously from pre-puberty, there's little expression of androgen receptor, but post-puberty in men, it rises exponentially, but it declines very slowly until the 8th decade, the amount of actually androgen receptor expression. Not to say the androgen levels are exactly the same, but the expression changes. So there is one of the studies that we just submitted for approval in Madrid is for trying to understand the androgen receptor, interestingly, the same gene variant that we're looking at in baldness and drug response anti-androgens in women for hair loss. We're looking at the relationship between those genetic variants and the risk of severe disease or mortality in patients. So we're going to actually collect DNA samples, analyze the CAG repeat in the androgen receptor, and correlate it to the disease severity of hospitalized COVID-19 patients, both in men and women. So that would be an interesting way to link this directly the androgen receptor, not just circulating androgen levels that are challenging sometimes to anyways measure, but actually the androgen receptor to disease severity. That would be very telling about this whole theory.
Okay, so what are your next steps? Point. I'm sorry, Doc. Go ahead.
No, I was going to say you make good points, and no surprise that you're good at that, picking picking looking at the data and coming up with a fresh take on it. And so even though androgen levels go down as men age, as Carlos mentioned, the prostate cancer disease is something that you see with age in men. And even though it's long been a conundrum that, as men age and would argue their androgen levels come down, their incidence of hair loss goes up. So it's not immediately obvious how those things work, but it is obvious, unrelated to hair loss, that the androgen receptor is an important mediator to induce the expression of this protease that the COVID-19 virus uses to get into the cells. And so, two things that, we always say true, and unrelated, or true, and related. And that's what we have to figure out.
Okay. So
let me
say
one thing that it's very important, Ken. There has been a study, an experimental study in mice, in 2017. So it was with the previous coronavirus, the SARS-CoV virus, but they did this experiment that really proves the role of the androgens in the infection. So I'll give a brief summary because this is real evidence, an experimental evidence that androgens are key for the infection. So first of all, when they get young mouse and try to inject the virus, the young mouse do not die. So they have to give the amount of virus to the young mouse to die that actually the water in the injection kills the mouse. So it's a 10 over 4 times the usual dose that usually takes to kill an adult mouse. So they did that in a real experiment with many mice. So while the mice start to age, male mouse start to be more vulnerable. So they require a lower dose of the virus to be killed, while the female mouse, they need more virus. And while the age continues so let's say they get older mice, the females start to be more inclined to death, while the men continue to die as they were before. But now, take a look. If we use a medication that is called flutamide to block the androgen receptors, you get the adult mouse, you try to kill them with the virus. The usual dose that kills 100% of the mouse does not work as well. So 20% of the mouse are alive if they are using an androgen receptor blocker, which is a very mild androgen receptor blocker called flutamide. And they only gave before the inoculation. They didn't give this medication during the disease itself. They try to protect the mouse before and the week before with this medication. While for female mouse, nothing they did changed. Let's say if they gave a medication that blocked the estrogen, it wouldn't change much their death. Now, if they remove the ovaries from the female, that would turn them more into a male-like phenotype regarding. So they would lose the protection of the androgens. They would die a little more. So, anyways, this is the brief summary, and that's a very interesting insight because even though the viruses are not the same, and those are mouse, that they are not humans. This is a controlled experiment. So the mouse, they are not smoking, they are not obese. There's not these other factors. They're only analyzing.
Well, we didn't know that the mouse were not smoking.
Yeah, could be. So
that's good data. That's good. That's important data, Carlos.
Good data.
That was a very good study, actually. What he's pointing to, it did show, even though it was a small study in mice, that prophylactic dosage, and I think it was 6 times or 3 times prior to a lethal dose infection with SARS-CoV-1, 20% of adult mice survived versus 0 on the control. Again, it was small and it was this, but it was very encouraging because this is a lethal dosage. So again, there's quite a bit of evidence. I think we're all in agreement that's an interesting area.
Sure.
We're obviously excited to try to share this with the world and try to see if this can help our hypothesis. So,
well, how do you guys envision applying these theories and these findings to practice?
So we have three areas that we're looking at: epidemiology, and as I said, it has limited utility sometimes, but it's telling and help convince the rest of the world that maybe this is useful to test. And for that, we are actually
already
with several
started on
hospitals.
that. Yep.
So we're partnering with several hospitals
started
in the United States with that one.
Mm-hmm.
Okay, start again, Andy or Carlos, whoever wants to speak.
Okay. Also, I just wanted to tell that we already started the epidemiology surveys. So we're looking at the whole Rhode Island health system for possible links between the use of medication and decrease of severity. But actually, the main thing is to look for applied therapy, because even though we're looking at the data, sometimes the data is not precise. So, for example, if we were looking at the data looking for hair loss or androgenetic alopecia, I would tell you that maybe only the dermatologist would write that in the chart. I'm pretty sure that a cardiologist wouldn't write or flag that diagnosis in a patient's chart.
Sure.
So it would depend on many variables. So the main thing is actually to do a clinical trial. We have enough data, animal data, biologic data to embase this trial. So as Andy was saying, we have some. First issue is that when you block the androgen pathway, you can increase the subject's risk of thrombosis. That is not true for 5-alpha reductase inhibitors like Finasteride and Finasteride, but that's true for any other blockers of the androgen receptor, like flutamide, bicalutamide, and also the blockers of the whole axis. So we have to be careful, because if you use a medication that really blocks the androgen receptor, we might increase the risk of thrombosis in someone. So that is not a good prophylaxis trial. So the prophylaxis trial fits well a model that we would use a medication that is very safe, with no increased risks for death or severe side effects.
So let's make believe you're speaking to a 3-year-old or the media, and well, so if someone was to ask you, so okay, we have these findings. They're certainly provocative, as Ken said. What are your plans to potentially help people with these findings?
Mm-hmm.
So we have several plans that we are in the process. We are waiting for approval to conduct a study in patients that are hospitalized with an antagonist for the androgen receptor, specifically bicalutamide. So we're going to it's a small study initially we're proposing, which is only in 10 patients, just to see if there is any positive effect in these patients. Now, of course, these studies are difficult to conclude a lot from, because 90-something% of patients do recover, but we kind of akin it to sort of like a phase 1 study for safety for this, and see if there's any response in these patients. So that's the one thing that we're doing to take it into practice. The second one, Carlos and I are applying both in the Rhode Island, and I am actually applying both for the U.S. military, and we're going to look at other places for healthcare workers, to have a prophylactic of a 5-alpha reductase inhibitor. Those do take longer to take effect, but it would be telling if there's several hundred people or thousands of people will be taking these prophylactics, and we'll see a different rate of infection or disease severity. So these are the two practical things we're doing. We're also trying to study, obviously, on the diagnostic side to see if there's a way to predict if somebody is going to either be a responder to anti-androgen, if it proves that androgens are effective treatment in some people, but some people it might not. And at the same time, you'll let it see if there's some correlation to disease severity. So those are from the clinical side. And then, of course, there's the epidemiological side, which we're collaborating not just in Rhode Island, but in other states.
And that's big, too. So, you've got prospective things, Spencer, that, you plan and go forward, and that those take some time. And then an important part of this is just getting this idea out there, getting this concept out there so that when folks can go back and do chart reviews, do epidemiology, and see some of these patients who've had severe lung disease with COVID-19 and see, was there a difference in any of those that were on concomitant medication for androgen modulation, whether they were on medications for, older men with prostate cancer who were on anti-androgens, or were there none? Were there people who were on 5-alpha reductase inhibitors for benign prostatic hyperplasia or hair loss, or none? And so both prospectively and some retrospective design chart reviews will be very helpful. But the key was to get this idea out there and get people to actively start thinking about it and looking.
I think that's good.
Yeah, I think that's the most important point.
I'm sorry. Go ahead. Go ahead, Andy. I'm sorry I cut you off. Start again.
No problem. The reason, Spencer, I even contacted you originally is that, besides knowing you, and I think this was an interesting information, is we're trying to get the word out there. This is not a commercial entity of ours that we're trying to do something with.
Sure.
This is purely, we think it's an important message. We think we found something very interesting and possibly could change the outcomes for a lot of patients. And we are not actually in the field of infectious diseases, nor are we connected with the CDC and other people, but we thought it's a discovery worth sharing with the rest of the world. And if some people either can look at retrospective charts or have the ability to even justify why they would do a treatment on a patient with that, we think that knowledge should be out there, given what we theorize, at least at this moment. So that was kind of our goal, and to get the message by publishing, which is what we normally do, and talking to people like you who can actually get the message out there. Dr. Washenik should echo and make his point, because I think it's an extremely strong point that, first of all, even if this proves true, which is still an if, and yes, we do think it's an interesting theory, maybe there'll be a higher risk eventually for people who are bold to contract the disease. Yet that doesn't mean that they're walking around and just giving people disease, even if they were the higher risk. So we want to be very careful. We're not singling out people who are bold or suffer from androgenetic alopecia as people who are walking around and spreading the disease, or people that are in any sense with higher risk for spreading the disease.
I mean, we have enough social problems. We don't need that.
Yeah. So that's not the point here. This is an observation that comes because we are researchers in hair. We happen to notice this effect with hair, which sometimes you notice something in a certain phenotype and it makes sense, and you look at it and say, okay, maybe that's a clue to what's going on, but really it's about androgens. And there's lots of diseases in human beings that relate to androgens that have nothing to do with hair. Hair is just one manifestation. So it's interesting to look at it on hair, and I think for this particular blog, it's exciting, interesting thing, but it's not about necessarily hair. It's about androgens, which happen to also predispose men for hair loss and women. But It's not what we're talking about, and it's not that they spread the disease more, or they should be worried more or change anything. I think, again, if you're concerned from what you heard in this blog, I think you should talk to your physician.
Yeah, I think you made that point wonderfully, Andy and Spencer, early on at the outset of the calls, and I think though that's a good takeaway message from the discussion. In addition to the great potential promise for insights into potential treatments for the lung involvement in COVID-19.